Good evening, everyone. We welcome you all to yet another academic session of the AOC and Education Vertical. This particular session, we have tried to do something different this time. We are trying to see, a panoramic view and discuss the most important original research and review article publications, which has happened in the first half of this year. So, and we have named it World Literature Review in Pediatric Neurology. So we are not going to discuss the studies in details, but we are going to just go through what are the important studies that have happened globally as well as in India, and which has relevant, clinical application in day-to-day practice. So without doing further delay, I would like to introduce today's moderator. Today's moderator is Dr. Prashant Johri, who is an associate professor in the Division of Child Neurology at the Department of Pediatrics at AIIMS New Delhi. He's a colleague and he has been a faculty at AIIMS New Delhi for last 7 years now. He has done his DM from PGMI Chandigarh in pediatric neurology. He has more than 60 publications in peer-reviewed international journals and has contributed to almost 25 chapters. He has specific research area interests like non-invasive neurostimulation in pediatric epilepsy, electrographic status in slow wave sleep, and CNS tuberculosis. And he has a reviewer in multiple international peer-reviewed pediatrics and neurology journals. So over to you, Dr. Prashant, to conduct the rest of the session.
Thank you, sir. Thank you, Dr. Anayata, Dr. Kavita, Dr. Kaushik, and our colleague, Dr. Bishru, for asking me to do this World Literature Review for AOCN. So what we will be doing here is that in the next 60 minutes, we'll walk through some of the interesting articles that got published since Jan 2022. And we have taken that liberty to cut short on few of them, and we have selected 33 articles because in the interest of time, we'll not be able to cover all. So there was no stringent criteria for doing that, but we chose those that may be of interest to all of us. So Dr. Akash, who is a DM resident pediatric neurology at AIIMS New Delhi, a student, so he will be presenting presenting you the world literature. Over to you, Dr. Akash. We can start.
Sure. I'll share my screen.
Yeah.
Is my screen visible, sir?
Yes, the screen is visible and you are audible.
Okay, so I'll start now then. So I'll start.
Yes, you may.
Yes, sir. A very good evening to all. And first of all, I want to thank all the AOCN members for giving me the opportunity to present in this forum. So we will be, as sir said, we'll be quickly reviewing some important articles pertaining to the pediatric neurology that have been published recently. So the literature search-wise, the journals we had screened are some of the most prominent 18 journals. So among these 18 most journals, we selected articles which were selected in the first 6 months, and we focused on the original study articles and some interesting review articles. So we were able to screen almost 600 articles, and among those which were relevant to pediatric neurology were almost 140, and we had to narrow them to just 33 articles for time's sake, and we had no any strict selection criteria as such. But we were able to club the articles under some headings so that we can have some continuity. So first we'll look up some articles regarding epilepsy. So we'll start with the article published in Epilepsy, which is on epilepsy syndromes. So epilepsy syndrome, as we know, is uh, characteristic cluster of clinical and electroneurological features, which is supported by some specific etiological findings, and it has a specific age at which it presents, and it is usually associated with some comorbidity, specific prognosis, and treatment implications. This part we all know. But the new addition part from the ELI is that they have given some specific etiology-specific syndromes, and they have given the scope for possible evolving syndromes and syndromes where we cannot confirm with lab findings at that time. And they have trying to find out, formalize the naming of all these epilepsy syndromes so that it can give a uniform method by which people from all of the world can report and collect data so that we can analyze them and get better significant reports. So they are giving some mandatory criteria and some exclusionary criteria, some red flag signs for classifying each syndrome. And it even gives criteria for those resource limited regions where they could be limited by, say, even MRI or video EEG to enable classifying specific epilepsy syndromes as much as possible. So, so as we can see here, they are first classified it as either a focal or generalized epilepsy. We are not going to go in depth of all this, just seeing a overall view. In each epilepsy syndrome, they are classifying according to the age. And so we have the focal epilepsy syndromes, generalized epilepsy syndromes, and we have the those progressive ones and with the epileptic encephalopathy ones. So we have a model syndrome, which is one of the most commonest one, which is the infantile spasms. So here we have the mandatory criteria, we have the red flag alerts, and the exclusionary criteria. So we have these spasms, which could be either flexor or the extensor, and EEG. It can have the classical hypsarrhythmia or the modified pattern also, and age is usually up to till 2 years. So these are all what we know. So the new part, which is the possible evolving syndrome tag. So we have the infants who have some brain injury. We can expect them to be predisposed to this condition, and even if we are now follow, we are finding some EEG abnormalities which are little likely coming in the range to be called as SIPs, but the child is not growing any spasms. So we need to like monitor the child under this tag as a possible evolving hips. And for syndrome without lab confirmation, so it is in the research limited setting where even without an EEG, when an experienced clinician has witnessed the epileptic spasm event, he could classify it as an infantile spasm if there is no exclusionary or any other red alerts allowed. So quickly moving on to the other related classifications. So here we have the genetic generalized epilepsies on one side, idiopathic generalized epilepsies, and the other side, those who might have an epileptic encephalopathy. And in the neonatal group, we have the etiology specific epilepsies, as we have mentioned before. We have the KCNQs, CDKLs, we have the glutons, all have given a special tag of etiology specific epilepsies. And coming to the childhood age group, we have the self-limited focal epilepsies. So they have given a renaming of the classical terms like Rolandic epilepsy, besides as selects, and this self-limited epilepsy with autonomic seizures, these are the punctatobolus types, and this childhood occipital visual epilepsies, these are the gastro types, and the new type, which is the photosensitive occipital lobe epilepsy, where just the photos after exposure to light, they might have some focal seizures, but in the EEG, they tend to have occipital spikes. So these are four self-limited epilepsies they are talking about in childhood, and the other generalized epilepsies, as we had shown before. Otherwise, then there's the epilepsies which are related to sleep-wake activation cycles, like CSWS and Landau-Kleffner's. And in variable age, we even have the Rasmussen's and Misael temporal lobe epilepsies being clubbed under the heading of etiology-specific epilepsy syndromes. So after reviewing through these classifications, we need to know like what is the chances of remission of all these epilepsy syndromes, and we are able to find one study from Journal of Child Neurology. So they had a prospective study in Spain, and they had included around 680 children, and they had removed all those children who had consulted other hospital to avoid the referral bias and all. And they could see the children with the centrotemporal spikes and familial self-limited infantile epilepsy were having almost 100% remission rates, while symptomatic VIS and those with neurological deficits without any specific syndromic diagnosis performed poor. And next section will focus on the newer anti-seizure medications with regards to pediatric population per se. Though centrotemporal spikes are self-limiting, there are subgroup of children who might need anti-epileptics, and though oxcarbazepine, which is our gold standard drug, it might not be suiting some patients. So those who might prefer a lower side effect profile drug like lacosamide, the study has shown almost 83% of patients are achieving seizure freedom, and that too 72% of them in the first 4 months itself. And the dose they have used here is almost 5 mg per kg, and only transient somnolence was noted in the study. And now we'll discuss about developmental epileptic encephalopathy syndrome, which is related to the CDKL5 deficiency. We chose this because with the emerging exome studies and all, we are often getting so many CDKL5 deficiency disorders. So a review article is chosen from Lancet Neurology regarding its clinical features. So it used to be recognized as a Hanfield variant of Rett syndrome. Now it is separate developmental epileptic encephalopathy. As you can remember, it is the etiology specific epileptic syndrome. So it is characterized by early onset seizures. This one characteristic seizure type is like it starts as a hypermotor seizure, then it has some tonic events and ends with a spasm. So it is a hypermotor tonic spasm sequence which occurs in about up to 50% of the children affected, and most are predominantly refractory to polypharmacy, and they have a cerebral visual impairment in which we can say that the visual impairment is due to the central rather than the peripheral cause. And these children are having so much comorbidities in regarding nutrition, regarding sleep, and musculoskeletal problems. So they have dedicated a separate database to collect info on them and have a separate clinical severity assessment scale per se. And currently, whatever benefit we are obtaining are from ketogenic diets and vagal nerve stimulation. So it basically opens up to the new research area and the new drug, which is ganaxolone, which is again being published in Lancet Neurology. So ganaxolone is a neuroactive steroid, and in this, the children with this CDKL5 deficiency disorders, those who had at least 16 major motor seizures in a 28-day observation period were selected. They were given the drug, which was weight appropriate for 17 weeks. And the median percentage reduction they could observe was up to 30% in those with the drugs group and just 7% in those with the placebo group. And the side effects were not very very alarming. Only somnolence and some pyrexia were noted. So it could be a game changer in this epileptic encephalopathy syndrome. Next, we move on to another sinister neurocutaneous syndrome, which is characterized by refractory seizures, which is the tuberous sclerosis. So this is a Chinese study in which they have tried to find whether we are able to reduce the seizure burden if we diagnose a disease prenatally. And they have in a population they have given anti-seizure medication and the mTOR inhibitor as soon as they diagnose it prenatally. So here we can see it has a cohort of 273 students, 273 children, and among those, those who were diagnosed prenatally were 31. So the individuals diagnosed postnatally were the remaining 242. So those who had epilepsy were comparatively lesser in those who were diagnosed prenatally, and they had a better developmental outcome also. So in those who had 31 who were diagnosed prenatally, uh, 18 had started getting preventive intervention also. So in those 18, only 7 developed seizures. So basically, among those who received the uh, diagnosis prenatally, half were already on preventive interaction. This might have even shifted the in favor of prenatal diagnosis. But the thing to note in this is like the epilepsy occurrence rate was actually significantly lower in those groups who are started from an earlier age, and the combination they have used is sirolimus for 2 years, 1 mg per meter square, and vegabatrin up to 50 to 150 mg per kg dose over for a period of 1 year. but sadly they have not given their experience with the long-term side effect profile of these drugs. So we move on to the next study, which focused on focal epilepsy, tuberous sclerosis. So, can vegabatrin be the answer? So, we have 85 patients who are having the diagnosis of this tuberous sclerosis, and the vegabatrin they are giving at around 100 mg per kg for a duration of almost 51 months, which is almost like 5 years. And they have mentioned like there is a 23.5% of the population was seizure free for at least 12 months, and 52% were more than 50% seizure reduction responders. And they had found out that younger onset of focal seizures, along with calcification of the largest tubers, were most indicators of poor response to vigabatrin. And the even more important thing to note is that they didn't have any visual complaints coming from those children per se. And when they did the visual tracking also, it was almost normal in those 85 children. They had done a electroretinogram in 12 children, and among those 12 also, only one had mild ERG changes. So, according to our current practice protocol, we are giving vigabatrin roughly around 6 months, maybe 9 to 12 months at max. But here, even those who didn't respond had received vigabatrin for 12 months, and those who responded were given up to 5 years. So the visual complaints might be little overhyped, but we need to keep that in mind. So next, coming to the age-old question, whether we should give Levara as a first-line treatment for neonatal seizures. So one landmark trial in this was the NeoLab 2 study, which was comparing equal dose of phenobarb and Levara. But the study favored phenobarb only. What one important point in this study to note was that adding an additional dose of 20 mg per kg to Levara increased the response by 8%. So in this study, they had used phenobarb of 40 in one group of children, and another group it was lever up to 100 mg per kg. Though their results were not statistically significant, their adverse effect profile and efficacy was similar between the two. So we need to do more research on up to the maximum tolerated rate of dose of levera, and whether it could have a equivalent response with that higher dose range. So next to coming to the newer drug parampanel. So parampanel is FDA approved as monotherapy for focal seizures in adults. So it is approved for the as an adjuvant therapy in children. So phase 4 trial retrospective data was collected. So we have two groups of children, those who are pre-adolescent and the adolescent. So it is they have used the retention rate as a marker of treatment efficacy. So retention rates were almost 50% in both the groups, and more than 75% seizure reduction was almost 30%. But the discontinuation rate is like little higher for both the groups. It's almost 20%. And the common complaints they used to have behavioral issues, aggression and somnolence, irritability, which were contributing to the drug discontinuation, and psychiatric symptoms were more likely with those who were having psychiatric disorders. So, parapanel in those seizure semiologies which were most responsive to parapanel were focal aware seizures, and atypical absences seem to rather get precipitated by parameters, so it has an unfavorable profile in atypical absence seizures. Then the question which we always face while stopping anti-seizure drug, what will be the risk of seizure relapse and what will be the long-term outcome after discontinuation? So 269 children were evaluated for this, and the mean age of diagnosis was predominantly around 6 years, so it was in the younger population, and most were idiopathic without any structural correlate. And it was found that there was 33% relapse, and the median time was around 8 months. And most of the relapses were happening in the first to 4 months, and they had well controlled with one seizure medication itself. And the parameters they have found correlating with relapse were adolescent age at diagnosis, abnormal EEG findings after withdrawal. Sadly, they haven't mentioned why they had done EEG after withdrawing the anti-seizure medication, the other is, and the high number of anti-seizure medications. Uh, those who are having high seizures on anti-seizure medication. So these three predicted the relapsing tendency. And the MRI pictures the hydrocephalus and cortical malformations along with genetic epilepsies were more prone to have relapses on stopping the anti-seizure medications. And coming to ketogenic diet in superrefractory status epilepticus. So we know that starting KD early in SRSE is very vital to have a better outcome. But sadly, these children will be on anesthetic drugs, which can cause gastroparesis, hemodynamic instability. This will stop us from starting enteral nutrition. So it will stop from giving an enteral ketogenic diet. So here comes parental ketogenic diet to address that issue. And this study, even though they are retrospective data of just 14 children, they are finding it to have similar efficacy and not much serious adverse effects between the two. And this was their protocol which they had used for reference. And the epilepsy had published an article for finding some biomarkers which for to follow up on these KD therapy patient, different KD therapies actually. So they have found out that those who had on classic ketogenic diet, their HbA1c levels were low as 4 as much as 4.5% compared to the MAD diet, which was as around 5%. It is still little on the lower side only. So it was correlating with better compliance to the treatment. While for association with good seizure control, they are having plasma carnitine levels and a ratio which they derive by dividing the blood glucose level estimate along with the ketone level. And another area of interest, which is electrical status epilepticus in sleep, the classic teaching has been to start steroids only if there is a spike wave index. It used to be over 80 to start, then it became 50% to start steroids. But actually, what we observed was that those who had less than 50% and more than 20% sleep-induced electrical activity, this group, so even this group had benefited from getting steroids, and their behavior scores had actually improved in up to 70 to 80% of the population. So whether we should have that strict spike wave index of more than 50% in the diagnosis of ESES for starting steroid, that needs to be researched. So we have finished epilepsy so far. Then, while discussing about the neurobehavioral issues, the core thing which we will be discussing is autism. And one of the most raging questions in autism is why is there a male predilection for autism? So basically, in autism, we know the one of the etiologies which people focus on difference in the interconnective pathways in the brain, and the network which they are focusing is on the salience network. The salience network basically is a somato emotional network which helps to integrate the sensory information to an emotional output. So the cingulate gyrus and the insular areas are the key areas for these networks. So what they have found out was that those salience network areas are affected by the ASD risk genes, and this has an interaction with the sex predilection, which may male bias in autism prevalence. So this was a nice article. So next, coming to the another question which came as a result of the COVID pandemic, whether screen time exposure in children is leading to pandemic, we can say, of autism spectrum disorders. So it was conducted in Japan. So around 84,000 mother-child dyads were followed up. So their outcome measure was based on number of as an odds risk ratio based on the cost of exposure at 1 year of life. So they had found out that those children who are exposed to higher screen time at 1 year had an association. But the thing to note was that association was only among boys, and not in girls. So they try to explain the mechanism. So they are saying like the microwave radiations or light stimulation of the AMPA receptors or MECP2 could be associated with the autism. And these MECP2 receptors and all, there seems to be some sex differences reported among them, might explain this finding. But then we have the second issue among the children with autism, which is sleep hygiene. So melatonin rhythm is being examined in this. So we have 41 autistic children and 24 typically developing children. What they did was they studied the sleep parameters and they took samples, salivary melatonin samples nearer to the sleep time, which is the dim light melatonin onset. So we can see, so this was their sleep onset time. So starting from -3 hours, they serially measure the melatonin level. So this among the autism children, we can see there is a lag for this to peak, and the peak level is also not as high as in the typically developing controls. And so we had the RCT, whether melatonin treatment could improve these children. So we had three arms, one with a low dose melatonin 1 mg, little higher dose melatonin 4 mg, then placebo. And as expected, there was a sleep onset latency shortening by 22 minutes in 1 mg group and 28 minutes in 4 mg group. And next, among the pediatric ischemic patients, so this study has found out that those children who are having stroke are inherently more prone to develop autism. And among those, if they had more comorbidities like epilepsy and focal neurological deficits, they are prone to develop autism. So these children should be routinely screened for autism. So we have completed two of more heavy chunk of our pediatric neurology. So this week move on to the neuroinfection part. So first is tubercular meningitis. So this review article was interesting because it was showing some new areas and caveats of research in TBM, like whether increased dose of rifampicin is needed, whether addition of some linezolid to the standard ATT, whether we could start aspirin with corticosteroids earlier. So all these studies are underway, and they are recommending Gene Expert Ultra for CSF studies, which has a sensitivity of up to 70%. So they have some biomarkers, and the thing to note among these biomarkers is that there's a leukotriene for hydrolase gene, which seems to predict whether the patient will be a responder to DEXA, which we are giving. So it might predict the outcome also, and the neutrophil associated transcripts. So they were abundant in those who had high-risk reactions. And then next common neuroinfection in our subcontinent, which is the NCC. So one problem which we are left with is persistent neurocysticercosis. Those who are having viable residual cysts on a 6-month follow-up, they are divided into three groups. One received a combination of albendazole and uh, praziquantel, while the other had placebo and the other had just albendazole. So the combination treatment group are showing a better efficacy in achieving clearance of the cyst when compared to the others. The rate of calcification and the seizure reduction. The size reduction was highest in the combined group, while the rate of calcification was identical in all the three groups. No difference in side effects were observed. Then neurodevelopment part. So I wanted to discuss about the radiological mimics in PVL because with our increasing survival rates of all our preterms and a better NICU care, we are having so much periventricular leukomalacia. So it's better we know about the mimics. So this study has classified based on clinical subgroups as well as the mimickers on the either it is inherited one or an acquired one. So they have tried to give a flow chart by this. So I'm not going to give in detail of this flow chart. So we'll see this MRI findings, which is a classical PVL. Here we have the periventricular hyperintensity and the irregularity in the ventricular margin with the blunting of the posterior posterior horn. So here we can see just the anterior part with normal looking uh, ventricles. So this is mostly it is characterized in spastic paraplegia. Next, we have this periventricular hyperintensity, but we can notice some minute cysts here and there. So it is a pattern known in mitochondrial diseases. And this one, so another important thing we need to know is about the clinical setting at which the MRI was done and the patient parameters also. This was basically had a history of like 1 year child had some fall and outside physician made a MRI and was referred as some leukoencephalopathy or something, but it actually was a terminal zone of myelination and it is a normal finding. So we need to integrate the clinical finding along with the radiological finding. So we have some red flags for the reader imaging like the brainstem morphologies or cortical involvement and red flags for the clinical history, like that's having a progressive course. So it's a clinical radiological diagnosis. So dystonia, so in it is seen that even in PVLs, those who are not having those GP hyperintensities, they might have a microstructural damage. This might be adding to a dystonia, which we are not expecting them. So we are under screening them, and this might be actually contributing to why the children are failing their therapy, being treated as spasticity. So we need to keep an eye out for dystonias and meta-analysis, which was highly critical of the neurodevelopmental therapy. So it was actually a combination of four meta-analysis, which in which they had done comparing NDT with control, low dose and high dose NDT, activity-based approaches, and body function structures. They are strongly recommending against using in neurodevelopmental therapy in children and are advising activity-based learning and therapy for those children with CP. Next, neuromuscular effects. So the boom of gene therapy was mainly experienced in SMS with all the risdiplam, nusinersen, and zolgensma. So it's right to discuss some of those effects of those studies. So risdiplam study, sunfish study. So 120 children had received risdiplam, and serious adverse effects were similar to both. And the we used the motor function measure score, which is a 32-item score, and there was at least a score increased by at least 1.36 compared to a fall of zero point 0.2 in placebo. So Rispiflam obviously performed better, and it performed even better in a younger group. So it is important to start them early, and those with the copy numbers of more than 4 had greater improvements. So we can see from this graph that this is the Rispiflam arm. So it has a better improvement while the placebo actually dipped as expected in the disease course. So next we come to the nusinersen in SMA type 1. So in SMA type 1, the children are having more feeding issues. So we have a score to measure that FIOS. And after getting this Spinraza for 2 years, we had seen that CHOP index score, which is the motor score, actually improved. But the bulbar score did not improve at all. It either remained stagnant or persistently deteriorated. And their hypothesis that maybe there was a much vulnerable region in the brainstem nuclei and the concentration of the drug which we are giving through the LP did not reach sufficiently in the brainstem. So a systemic treatment with Zolgensma might be able to more beneficial in these conditions. Then we have the juvenile myasthenia gravis in a France population. So most were generalized forms, and they have noticed that over the past 10 years, physicians are moving from the classical corticosteroid-based treatment to starting even Ritux upfront. So 24 had received rituximab, and 13 had received it as a first line, and when they analyzed, those who had received rituximab per se had better outcome, and those who received ritux had as a first line actually outperformed those who had even received ritux as a second line. And in terms of their steroid sparing effect, it was a class 3 evidence. And coming to the neurocritical care, so I will talk about some autoimmune conditions. We like GBS and Adams and all. Though they get usually settled with IVIG, PLEX, MPS, etc. there are some fractions of children who get stuck and they become refractory. So this method might be answer to one such thing. So the zipper method actually hypothesizes that IV, the plex which we start initially removes the IVIG and the cytokines, and after we remove it, there's a rebound redistribution of the antibodies and rebound production of the antibodies. So after we, as soon as we do the PEX, the next day they are giving IVIG to bind to all these things, and in the third day doing other PEX. So they alternate PEX and IVIG, and they increase the cycle to up to 7 or 10 times, and they find that it is having actually a great reduction of mechanical ventilation. Though it is based on a very small sample size study, but it might be helpful in those hard refractory cases. Then coming to one of the most neglected fields in our pediatric neurology, which is sleep. So unless the child and the family comes straightforward with sleep complaints, we don't routinely ask for the sleep complaints also. And basically, some children with behavioral issues might be actually harboring some sleep issues, which is causing to all those behavioral problems, and they are actually getting under treated and under recognized. So doing PhD, as we know, is cumbersome and is stressful for both the child and the parents. So for using a reliable screening tool necessary. So we try to make a reliable screening questionnaire based on the ICS D3 criteria, and we are able to make the questionnaire based on 750 respondents and comparing 100 cases with their gold standard PSG reports. And this questionnaire, as expected, had a lesser negative predictive value, supporting its use as a screening tool rather than diagnostic tool. So trauma in neurology is also important because we are often seeing children after coming from the neurosurgery interventions getting started and eptoin prophylaxis, even though meta-analysis have shown very weak evidence to support its efficacy in reducing early post-traumatic incidences, which is in the first 7 days, and had no effect on the long-term outcome. So this study, they have only used levera per se in those children with traumatic brain injuries. And basically, they had seen like only around 14% were having those seizures, even though they had getting levera. But they had compared with this with the previous study on Epstein, where their occurrence was just around 10%. So though they can't be compared head to head, so if at all they are giving any anti-seizure medication for post-traumatic seizure prophylaxis, maybe Epstein is preferable than Levera. And the next important thing is describing the prognostic features of traumatic children with traumatic brain injury. So the basic school of thought is that mechanical injury causes much volume shift and intracranial pressure, which is easily detected in a CT. But the thing is, doing a CT as soon as the child comes in, it is usually time consuming, and the thing is that it's not just the primary brain injury which is leading to mortality. There is a secondary component also. The secondary component is contributed by the body's inflammatory responses, lymphopenia, thrombocytosis. These are all leading to a systemic inflammatory state. They will lead to mortality also. So whatever prediction scores that are existing, like LNC, CT based score, all are based on CT grading only. So we usually lose valuable time while waiting for a CT. So they had validated a nomogram based on the sex and basal system status. It's just based on the CT and the simple blood test, which is a platelet lymphocyte admission ratio. So using this nomogram, they are given weightage, scores weightage for each of these three risk factors. And they concluded like those who are having a score of around 135 are more prone to have higher risk and worse prognosis. So how as physicians we can contribute to the literature uh, data is that we need to have a more efficient collection method and data retrieval system. We need to focus more on digitalizing of the hospital records so that we don't miss on all those rare cases which we encounter. And we, whatever studies we do, we need a better robust methodology and a very good study design. After all, the result what we get is based on what the data we see. So we need more research in fields which are of maximal interest as well as rare events equally. And the points we need to consider is like adult neurology has, when I try to go through the articles, pediatric migraine has barely few significant studies. So we are still lagging on this data in these fronts, and we need to do more research and add more good quality data so that we can get stronger recommendations, especially for even rarer conditions. And we need to try to replicate some adult studies in pediatric populations also. And we need to use the new genomic data, proteomics, all those data to have more curative therapies for neurodegenerative conditions also. Thank you.
Thank you, Akash. Thank you for finishing away in the record time. So, so what we have done is that we have presented the literature that is available in pediatric neurology. We might have missed a few what could have been interesting, but we thought these were good enough to be discussed in this 60 minutes. So to start the discussion, I would bring up that why we started with this, the terminologies and definitions, so that everyone is on board with the recent development in this classifications. We know that 2017 ILA has given this classification for epilepsy and seizures. So they wanted all these syndromes to be in line with that. And in that process, they have come up with these new entities like etiology specific. They are trying to assign a specific syndrome to them. So we need to be aware so that we can start those specific treatment and ensure that we are somehow going towards this precision medicine. So this is how we progress. And then there were some articles which were very small sized, but still I thought that they are actually bringing up good points to ponder over, and maybe for researchers to build up on them, and for clinicians maybe to give a try in their clinical practice. So one of them was that actually increased this, started this debate, was those two articles on tuberous sclerosis. So we know that there has been some talk or school of thought that says that if you start medicines even before you have these epileptic spasms in tuberous sclerosis, the long-term outcome may be good. But we don't know. We don't have enough literature to say. Maybe I'd like to have opinion from others also, that what is their thought process on that, because the drug that we have for TS, we are not able to give it for a prolonged period. So sometimes some people would want it to actually keep it as a resort when a seizure or epileptic spasm actually starts, which is the age by 6 months to 1 year. Before that, if you give, you might have already exhausted your prime your prime drug. So this is there, but yes, there are studies that are showing that maybe the long-term outcome is improves. And this study that we discussed has also given sirolimus along with vigabatrin, and there was no clear-cut clinical indications per se. The diagnosis was made on fetal MRI, a fetal echocardiography, and a few of them were genetically proven prenatally. The moment that these kids got birth, this vigabatrin and sirolimus was started. So this, and the last thing, and then before I'll open it up, is that zipper technique, which we thought there we often encounter those patients who are difficult to control. So there maybe we can use that. So maybe we can we'll be happy to answer any queries are there or any comments that anyone has. Over to you, Dr. Bishru.
Thank you, Dr. Prashant and Dr. Akash, for this, wonderful presentation. I think you can already make it out from all the superlative comments that you're receiving in the comment boxes. What was very impressive, that it's not just the number of articles, to pick those articles and then to discuss them in detail, but in a very concise way. So he was actually able to tell us the exact message that one should know from these articles. So very impressive. And Akash, I think everybody wants to see you. You have kept your video switched off throughout the presentation. It was a wonderful presentation and everyone must know who this person Akash is. So we must see your video for once. Yeah. So we are opening it up for comments from all the senior people, Shifali ma'am, Kavita ma'am, uh, Arijit sir, and everyone else, whosoever wants to, comment. It's open for comments and discussion.
It is very wonderful presentation. I think it is very important to have these kind of general reviews, because other one is a critical appraisal, but these are very important, and that's why we have this kind of a general watch. And this was a really exhaustive thing, because generally we do that for 1 month or so, but this was done for 6 months. It became very mammoth, and I think it was really well done and well mentored. And only thing is, in future maybe we may also right to put a critical clause on that, restrict the number from 35 and just say, because sometimes everything what is reflected has to be taken with the pinch of a salt. So in that situation, maybe maybe in the next time we may reduce the number to 20 and may have one thing on the critical part also, so that which what is the thing what you should keep in mind, because everything what they are saying is not necessarily true, because there is a catch. That is what I thought. Maybe that it has been very wonderfully done. And because when we do it, if you remember that we do only for a month, so that the numbers are less, right? So this was really mammoth. 6 months, I mean, it became a bit ambitious. I think the next time onwards we may make the articles 20 and have a critical element also added little bit, so that how to take it. But really, really well done. Yeah.
Thank you, ma'am. Thank you for the comments. I think you actually have raised the valid points that maybe next time there can be some improvisation on what we have done. Thank you.
Dr. Prashant, do you want to address the questions that are there in the question box? Dr. Bishwarup, you can take care.
Yeah, so Kavita ma'am has a question, Prashant, that can you elaborate further on the AIMS study on validation of sleep questionnaire?
Thank you, ma'am, for this question. So actually, this study was primarily run by Dr. Bishrup himself. So I think, Dr. Bishrup, you should be the person answering this query.
Okay, thank you, Prashant. Actually, this was a DM thesis of one of our candidates, Dr. Zulfi. So what we actually did was, ma'am, we went through the latest sleep classification, which is according to the ICSD-3, International Classification for Sleep Disorders 3, and till date there were no questionnaire based on ICSD-3. So what we did, we went through the diagnostic criteria of all the common sleep disorders, the common headings of sleep disorders, which are 7 in number. And then we took out the salient diagnostic features, we framed a questionnaire, we ran it through our panel of experts, which included Shifali ma'am, Dr. Prashant, and as you could see, people from pediatric pulmonology, pediatric ENT, then endocrinology, biostatisticians. So we had people from various fields who actually see cases related to pediatric sleep. And then what we did, we used a school as the community sample, and we had hospital sample as well. We had both healthy children who were primarily from school and from outpatients, and some diseased children who have more prevalence of sleep disorders like DMD, SMA, CP, and asthma. And after that, we ran it through 750 respondents. We used Cronbach Alpha. Then we came out with 28 items, which could be actually used as the final questionnaire. And then what we did, out of those 750, by random selection, we came up with 100, of which 68 were questionnaire positive for sleep problem, 32 were questionnaire negative for sleep problem. And then we looked at it with regards to gold standard evaluation with PSG and clinical evaluation. So these 100 children, they underwent PSG as well as clinical evaluation for gold standard diagnosis, and they also had the questionnaire evaluation done. So, and the person doing PSG and clinical evaluation reporting was blinded to the response of the questionnaire. And then we came out with the sensitivity specificity. So this is actually been validated between 2 to 18 years of age, includes all the common subtypes of pediatric sleep disorders according to ICSD-3, and has good sensitivity, specificity, positive and negative predictive values. So this is how it was done.
So isn't it that it is also giving us individual diagnosis also? This is not only screening, but in a way.
Yeah, so what we did was, although the numbers are less, but when we looked at individual subgroups, like, sleep-related breathing disorder, sleep-related movement disorder, insomnia. So most commonly we had these three. Others were not that prevalent in the sample of 100 in whom we did gold standard evaluation. But in those two also, primarily sleep-related movement and sleep-related breathing disorders also, individually we also had good psychometric properties. But when we overall look at the questionnaire, it has good psychometric properties, against a gold standard PSG and clinical evaluation. This is how it was done.
Thank you, sir, for explaining it.
Ma'am, we did include just parasomnia. So we didn't actually make the questionnaire thinking that we'll be able to differentiate REM with NREM. But yes, what we did was the questionnaire definitely included whether they had any, abnormal behavior or abnormal motor phenomena which happens in the night, so that, even it can be used by somebody who is not an expert in sleep. I mean, it doesn't even need maybe a pediatrician also. Even a simple physician or a healthcare person or a community person, once you train, will be able to, apply this question in the community, so that we can pick it up from community and then apply it in clinics. So the main idea was that. So we didn't go into that much of depth, differentiating REM and NREM disorders. But yes, we looked at all the disorders in a very simplistic way so that they're not missed out in the questionnaire. Yes, ma'am, it is available. Actually, it's published, and in the publication also it's available. And if anybody wants to use it, it's bilingual. It is both English as well as Hindi, so it is available. Yes, ma'am. Shifali, ma'am, you want to make any comment on the study? Because ma'am was one of the most important contributors in the study. She had made a lot of changes in the questionnaire when we had initially made it. Shifali, ma'am, any comments from your side?
No, you've said it really well. Obviously, during the process of development, everybody makes changes, but you've presented it very well. Yeah. Thanks.
Any further comments from anybody? Any concluding remarks from Dr. Prashant? Dr. Kaushik, you want to make any comment?
There are some questions from Dr. Sridhar at the beginning.
Ma'am, I think there were two questions which I already actually responded to them. One was, what was the dose of perimpanel that was used in that PROVE study? So that PROVE study was actually not an RCT, prospective RCT, it was a retrospective real world effectiveness study. So there they used 4 to 8 mg per day of perimpanel. And how long one can use melatonin in autism? This is the question which has not been answered in that study. So there is no, it does that has shown that yes, it improves the sleep onset latency, but how long you need to use that? This is something which has not been taken up in this study. So in clinical experience, maybe we can comfortably use it for a year or two. We know that there is no dependence that kids have with melatonin. It is quite safe as a procedural drug as well as for long-term modification of sleep hygiene.
Dr. Prashant, I think there is one more question in the beginning. It was, it's not exactly a question, but somebody, Dr. Jyotsna has commented that it's a wonderful presentation. She actually wants to know the names of the articles on KD and TBM. So she wants to know about the
yes. So one thing was that I definitely wanted everyone maybe to go over that review in Lancet that was published for tuberculosis. So that is one good. I don't remember there were a group of authors that were Swedes who have been working on tuberculosis for quite a while is one of the authors. Akash, do you remember the author? And then maybe we can share that publication, at least the name, so that you can actually download it on at your end.
So, by searching just tubercular meningitis Lancet 2022, it will be the first one on the search list.
Still,
I can share the
Yeah,
drive
you
link of
can
the
share
article.
the citation in the chat right now.
Yes, I'm good.
Dr. Prashant, in the meantime, Dr. Sridhar Joshi has asked, in clinical experience, what time before bedtime should melatonin be initiated?
30 minutes before you, so there has to be some structured sleep plan. That has to be regularized. The whole family has to then act in the same manner. And then if you add before 30 minutes before going to sleep, maybe 3 mg of melatonin is what we routinely use, although the study has used 1 and 4 mg. So you will possibly get the results. It is 30 minutes before the bedtime, and that has to be fixed a bit. It is not that you make it 8 p.m. or 11 p.m. the other day. It has to be fixed, and then you give 30 minutes before that.
The importance is to keep the sleep hygiene, which most of the people miss actually. Sleep hygiene has to be re-emphasized. And one thing regarding the Bishop that questionnaire which you had asked, just the CSHQ which you were using earlier has one question that whether the child sleeps with the parents, and that is taken as a negative. Here most of the children are sleeping with the parents. So that's why it's important of having social cultural sensitive tools. That's why the whole exercise, one other thing, and also obviously the categorization into diseases was not there in the CSHQ. So that is another need to have our social culturally sensitive tools for these situations.
Yes, ma'am.
So thank you, Dr. Bishwarup, Dr. Prashant, Dr. Akash, under guidance of Shefali ma'am. On behalf of AOCN, it was a very, very fruitful session, I could say, and I could make out that how much of lot of hard work has been put into compilation of all the articles. I really want to thank the AIMS team for doing such a wonderful job and giving an entire plethora of the knowledge of 6 months to the entire audience of AOCN. So with this, I think if Dr. Bishwarup is okay, we can end the session. And the next session is on 20th of July. That will be on neuroradiology session. So we look forward to meeting all of you. Thank you very much, Dr. Prashant, Dr. Bishwarup, Dr. Shefali ma'am, and wonderful job, Dr. Akash. So
Thank you.
thank you. Thank you so much, all of you.
Thank you, Dr. Kaushik.
Thank you.
Thank you. Kavita ma'am, do you want to make any remark?
No, nothing else from my side. I think it was an excellent session, such a beautiful compilation, and I like the flow of the articles, how it went from one to the other. And Dr. Akash did a stupendous job of finishing in time, and of course under mentorship of Dr. Prashant. And I thank Dr. Vishwarup and Shefali ma'am also. Excellent session today. Lots of learning. Thank you so much.
Thank you.
Thank you, all of you. Good night. Thank you.
ma'am.
Thank you. Thank you. Good night, everyone. Thank you.